Greetings and a warm welcome to everyone. I'm Srevshi, the assigned moderator from Planet. It is my proud privilege to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors and express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform, Planet. It stands as one of the largest live digital CMA platforms in India, providing a space for doctors to create and share medical content. Now, let's begin today's session, for which I would like to invite the academic chairman, Dr. A.L. Meenakshi Sundaram, sir, to take over. Over to you, sir. You can proceed with the talk now.
Thank you very much. I request Dr. Munian, President, ISA Pudukkottai City Branch, to offer his presidential remarks.
Good evening, sir. It's my honor to welcome you all for the online webinar conducted every week on Wednesday by Pudukkottai ISA City Branch, Tamil Nadu, in the name of Pudukkottai Bhudhan. Today we are conducting 9th episode of second edition. Last week on spinal anesthesia, we conducted last week on spinal anesthesia, which was attended by 672 delegates from all over India. The speaker also from all over India and India. Thanks to our academic chairman and to a respected professor Dr. A. Meenakshi. Our association represents the collective voice of our specialty, dedicated for promoting and anesthesia, like education and like our online webinar. Since we are the reputed anesthesiologists, we play a vital role in ensuring safety and well-being of our patients during anesthesia and other medical procedures. Today, we are going to conduct an online webinar on the topic of thyrotoxicosis and anesthesiologist perspective. Today's speakers are from Gitanjali Medical College, Udaipur, Rajasthan. The three topics are going to be discussed. First topic is thyroid function test and its anesthetic implications by Dr. Kanupriya, Sharma, PG student. Thyroid functions are crucial for diagnosing and management in thyroid disorder, which can affect your bodily functions and the energy levels and the overall health. Dr.Seema, Partani, Professor of Anesthesiology from Gitanjali Medical College, Udaipur, Rajasthan. Madam will speak on the perioperative assessment on optimization of optimizing thyrotoxicosis. Thyroid function is a thyroid function test perioperatively. Thyroid function it is also useful to detect the adequate treatment before surgery. On evaluation of comorbidities in both type 1 hypothyroidism should be evaluated before surgery, and also medical management used to be treated in patients with hypothyroidism. Hormone replacement therapy to be given. In patients with hyperthyroidism, anti-thyroid drugs to be given. Our ultimate aim is to bring the patient euthyroid state before surgery. And the third topic, anesthetic management, thyroid surgery by Dr. Alka, Chhabra, Professor and Head, Gitanjali Medical College, and Udaipur, Rajasthan. Welcome, madam. On thyrotoxicosis, from the anesthesia perspective, likely focus on the perioperative management and patients with the thyrotoxicosis. Some key points: perioperative evaluation. Thorough perioperative evaluation is crucial to assess the severity of thyrotoxicosis and its impact on various organs, system like cardiovascular system, respiratory system, and the neurological status. By evaluating perioperative test, the thyroid function test, echo, ECG, X-ray test, and all. Anesthetic consideration, we must be aware of the potential risk of challenges associated with the anesthesiologist in patients with thyrotoxicosis. These are high risk of cardiac arrhythmias, and cardiac antiarrhythmics should be kept in hand to manage if there is any complications. And intraoperative management, beta blockers. Nowadays, there are so many beta blocker forms are available for IV preparation and oral also. Post-op care is a crucial step to prevent early detection and prevent the thyroid storm during post-operative period. Post-op pain management is very important to reduce the stress response and avoid cardiac complication during post-operative period. Today we gather for online webinar. Our speakers from Gitanjali Medical College, are interested to share their experience among us. Welcome, madam. Thank you all, sir.
Thank you, Dr. Munian. Now I request Dr. Kannan, Secretary, to offer his secretary report.
Good evening, sir. Good evening, all. I am Dr. Kannan, Secretary, ISA Pudukkottai branch. Successfully, we are conducting 9th webinar of second edition of Pudukkottai branch today. Today, our topic is thyrotoxicosis in anesthesiologist perspective. Our president has elaborated well. I welcome all our eminent speakers to the webinar. Last week, 12th March, our 8th webinar was conducted perfectly with the enthusiastic speakers. The 8th webinar topic was spinal analgesia, technical difficulties. This topic is very much interesting and the special one. The subtopic was anatomy of spine and troubleshooting in getting subarachnoid space and USG guided central neuraxial block. Our moderator was Dr. G.P. Krivaran sir, President ISA TNSB. And the first subtopic, anatomy of spinal cord, done by Dr. M.D. Hamad Ali. He is postgraduate, ESA Medical College, Hyderabad. He has elaborated anatomy very well with his slides and pictures. It was very well. And the second subtopic is troubleshooting in getting subarachnoid space. This topic is done by Dr. Silpa Bhatt. He is assistant professor, NFI Medical College, Bangalore. And the third subtopic is USG guided central neuraxial block. It was done by Dr. Viral Pagas. Sir has elaborated this USG guided blocks very well with USG guided images perfectly. He is a consultant in PD Hinduja Hospital Center, Mumbai. And the last webinar was attended by 672 delegates. Thanks all for your kind support. We need your support to continue the webinar perfectly. We thank our academic chairman, Dr. Meenakshi Sundaram sir. We are expecting increased number of delegates attendance in upcoming webinars by the consistency of our webinars quality. Thank you, sir. Thank you all.
Thank you. Now it is my duty to introduce all these great faculty to the delegates. See, now these people are from a state full of desert, are known for its desert. But these people are going to give a lecture which is going to be like a oasis in a desert. And after listening, you will approve my statement that is, even though they are from a land of desert, their speech will be like a desert. So we have to enjoy that. See, it is all ladies program. Nari Shakti, we can see all four. Our junior most speaker, Dr. Kanupriya, is a third year postgraduate. Even though he is a junior most speaker, among the postgraduates, she is senior most. She is a third year postgraduate, and she has done his MBBS from China. So she is a foreign medical graduate, but her nose will not be looking like a Chinese. And Madam, the PG is pursuing digital media, and the content creator, he is a content creator interested in that digital era like any other youngster in this 2025 era, and she is integrating her interest in a balanced living. So she balances everything. Anesthesia is a balancing art. So she could balance everything. So we welcome the young speaker of today's webinar. It is followed by Dr. Seema Partani. She is a professor. See, now we are having two professors as a faculty. So one is Dr. Seema Partani. She is a professor in Geetanjali Medical College. So in addition to her anesthesiology qualification, she is delivering palliative care services. And on the society side, Madam is the president of Udaipur City branch. Actually, we visited Udaipur when they convened that ISACON conference. At that time, I was a PG. I attended the Udaipur conference, and Madam is a life member of many organizations. But leave alone this palliative care and anesthesiology, which many people are doing, Madam is a great dancer and a singer. So we are unfortunate to have her program today as it is a webinar and Madam is sitting. So she can sing but I think we cannot see her dancing. But anyway, it is her extracurricular activity. So we welcome madam also. Now another professor is also there. So she is a professor and head of the department, Dr. Alka. I met her in Sangli Miraj. She is a ever smiling lady. She is a ever smiling lady, and she is a good professor, a good guide, and I have seen her performing in Sangli Miraj. She is a faculty in many state and national conferences. Uh, she is a ACLS instructor. Same way, Dr. Seema madam is also a ACLS instructor. So these people are teaching cardiopulmonary resuscitation very well. And madam is an organizing chairperson of Rajasthan, ISACON. It was named as Rajesh Khan in 2023. And Dr. Alka is a recipient of Vice Chancellor Award for GMCH Udaipur, and her extracurricular activities are phenomenal. So, anesthesiology, as I said, it is easy for everyone. But madam is a great cook. So, she enjoys cooking. And again, we don't know when we will have the time to taste that. She is a good cook. And nowadays it is very rare to see females cooking. So madam is one among that. And she is interested in gardening also. So she is growing the knowledge in the students' mind and the trees and the plants in her garden. And she is interested in yoga also. So from her stamina itself, you can say she is a great yoga teacher. And more than that, she is interested in trekking. I don't know why she is doing trekking. If madam stands, the wind itself will take her to the height of the hill. So, but again, madam is doing trekking. Now the difficult part is to govern these two professors who can moderate. Two professors when they are faculty who can moderate. So only a professor of professors can moderate. So a teacher of teachers, a great legend. If I introduce Dr. Sunanda Gupta madam, the entire webinar time will be taken over by me. But as I said, when a person has performed so well, it is our duty to say, because at least a tip of the iceberg only we can introduce, because it is very, very difficult to introduce madam. But I want the delegates who are attending Pudukkottai Bhudhan should know we are having a great legend of an international standard is sitting as a moderator here. So we are blessed, the organizers, as stand today. I am literally myself and the Pudukkottai city branch are blessed to have her as a faculty, that too to moderate the great professors. And the delegate should know, madam is such a great lady. So she is a founder president and a governing council board member of the Association of Obstetric Anesthesiologists. See, madam is a visiting professor for Birmingham also. So she is a professor of international repute. That is the reason why she has been designated as Professor Emeritus here. And madam is an executive committee member of obstetric anesthesia. She is an executive committee member of Indian College of Anesthesiology. Whenever the teaching comes, madam will be there. And see, madam has delivered orations almost in all the states. So all oration awards, including, if Chennai, I want to say, she has won that 10th Kamath. You know, Professor Kamath was in SRMC, Ramachandra Medical College. Madam has won the award. And see, even now, Madam is teaching the youngsters. Even now, she is interested and she has won numerous awards. She has won numerous awards. So she has won a district award for exemplary services in medical field in Rajasthan. So that itself says it is not only exemplary service in Rajasthan, exemplary service in the entire world. And she has delivered the Venkatrao oration, Francis Memorial Oration, and the Achievers Excellence Award she has won. So everywhere, when the question of excellence comes, it can be replaced by Sunanda Gupta. That word itself can be replaced, and Madam has publications 144. We usually say 144 is banning order, 144 has been promulgated, but Madam has published 144 papers in peer-reviewed journals, and she has written chapters for 14 national textbooks and 8 international textbooks, which are all not a simple thing. So this madam, not only this, she is also interested in singing and dancing. Imagine So, madam possesses extracurricular activities also. What I want to convey the youngsters, please don't say that we are not having enough time. Just by joining anesthesiology PG, they will say, I don't have enough time, I'm only reading. But such a great madam, everybody is a singer and a dancer. I don't know how in a state of desert they are enjoying like this. So everybody should follow these eminent faculties. That is two professors and one would-be professor, because she will also be following their footsteps. Moderated by the great madam Dr. Sunanda Gupta, such a intellectual madam. We are happy to have you as our faculty for today's webinar. And actually, I rushed. I traveled like anything. This is the first time I have driven at a speed of 140 kilometers, which I don't want to do. But today I travel because I want to reach, I want to listen to madam. So now over to Dr. Sunanda Gupta, madam. Please take over.
Thank you so much, Dr. Meenakshi, for that erudite introduction you gave for all of us. But I want to correct you on one point. You said that we come from a desert. You have already come to Udaipur. So you must see the 7 lakes and then you will change your perspective about Udaipur. It's one of the most beautiful cities. So now coming to the topic, thyrotoxicosis. It is rarely encountered now in our urban population who undergo regular health checkups and are very, very particular about their healthcare. But then if it is left untreated, undiagnosed, that it can produce a variety of symptoms and cause concerns for the anesthesiologist. And the increase in thyroid hormones affects each and every part of our body, and suspected thyrotoxicosis should be adequately prepared before they come for surgery. And for the postgraduates, it's one of the most important topics because you get a long question, and when you get a long case, then everybody sees very enviously at you because this is the best long case anybody could get, thyroid. So without much ado, I would like to call upon our resident, Kanupriya. Can you start with your topic? Investigations in a case of thyroid surgery. Yeah.
Good evening, respected faculty members. Can you hear me?
Yes, carry on.
Thank you, sir, for such a kind introduction. In this session, I'm going to talk about thyroid function tests and its implications. What is thyroid? It's a butterfly-shaped endocrine gland located in the anterior neck at the level of C4, C5, just below the larynx and anterior to trachea. This picture here represents the hypothalamic pituitary thyroid axis, which is important in regulation of thyroid hormones. So, from the hypothalamus through the paraventricular nucleus, thyrotropin releasing hormone is released, which activates the anterior pituitary cells, which release the TSH or thyroid stimulating hormone, which further stimulate the thyroid gland to release T3 and T4, the thyroid hormones. One important point here is that this increase in thyroid hormones, this elicits the negative feedback mechanism, which then further stops the secretion of TSH and TRH, hence maintaining homeostasis in the body. Synthesis of thyroid hormones. Now, this picture here shows the extensive synthesis of thyroid hormones T3 and T4, but there are three main processes which are involved in synthesis. First is oxidation, second is iodination, and third is coupling. This part here, this represents the blood. This here represents the follicular cells which are present inside the thyroid gland in a concentric manner. And this part represents the colloid, which is the central portion of the follicular cells. Colloid is the portion where thyroid hormones are synthesized and then stored until they are required in the bloodstream. This is iodide, which this is the dietary iodide which we take in through our diet. This from blood is taken up by the follicular cells. It enters inside the follicular cells via the sodium iodide symporter, and is taken up to the laminal part of the follicular cells via protein called pendrin. Then it enters into the colloid, where through a process of oxidation it is converted into iodine. Iodide has to be converted into organic iodine in order to in order for the synthesis of thyroid hormone. And this oxidation takes place in the presence of an enzyme called thyroid peroxidase enzyme. Then after oxidation, there is another protein called thyroglobulin which is present inside the colloid, and this has active tyrosine amino acid over it. This thyroglobulin, when combines with the iodine here, this process is known as iodination, and takes place in the presence of thyroid peroxidase enzyme only. It forms MIT and DIT. MIT is monoiodothyronine and diiodothyronine. This mono and diiodothyronine will further synthesize the thyroid hormones. When one monoiodothyronine combines with one diiodothyronine, it forms T3. And when two diiodothyronine they combine together, it forms T4. And this combination, this process is known as coupling. And after that, when T3 and T4 are produced, they can be then transported into the blood whenever they're needed, or they can be stored until next use. Now, thyroid function tests, the group of tests done for quantification of TSH and thyroid hormones in serum to assess thyroid gland function. These are broadly categorized as in vitro, in vivo, thyroid antibody, and miscellaneous tests. These are the in vitro tests. These involve serum TSH, serum T4, total serum triiodothyronine or T3, T3 resin uptake, free thyroxine index, serum protein bound iodine, free T3 test, and tests of hypothalamic pituitary axis. In vivo tests involve uptake tests, which include radioactive iodine uptake or technetium-99 per tectinate scan, T3 suppression tests, and other miscellaneous tests which involve radiography, X-ray after barium swallow, bone scan, selective angiography, FNAC, ultrasound, CT, and MRI. Thyroid antibody tests, anti-thyroid peroxidase antibodies, anti-thyroglobulin antibodies, and TSH receptor antibodies. Now, in vitro test, the first one, serum thyroid stimulating hormone, this measures the serum TSH levels. It's the most sensitive and most reliable test for assessing thyroid function. Normal range is 0.4 to 4.5 MIU per liter. And if TSH is high, it suggests hypothyroidism. If it is low, it directly suggests hyperthyroidism. Now, there are 4 different generations of TSH assays, out of which third generation is considered as the gold standard. These TSH assays can assess TSH levels from 1 MIU per liter to 0.001 MIU per liter. This is the interpretation of third generation of TSH assay. Which is a single gold standard test. Normal TSH is 0.4 to 5 MU per liter. Normal free T4 is 0.8 to 2 nanogram per deciliter. Normal free T3 is 2.3 to 4.2 picogram per ml. If free T3 and T4 levels are normal and TSH ranges between 0.1 to 0.4 MU per liter, it is diagnosed as subclinical hyperthyroidism. If both T3 and T4 are increased and TSH level is less than 0.03 MU per liter, it is diagnosed as overt hyperthyroidism. And similarly, if both T3 and T4 are normal but TSH values range between 5 to 10 MU per liter, it's diagnosed as subclinical hyperthyroidism. If free T3 and T4 are decreased and TSH levels are more than 20 MU per liter, it's diagnosed as overt hypothyroidism. Next, serum thyroxine. It measures the level of total that is bound in free T4 in the blood. Normal range is 4.5 to 12 mcg per dl. If T3, T4 levels are high, they directly suggest hyperthyroidism, can be Graves' disease or thyroiditis. If T4 levels are low, it suggests hypothyroidism, can be autoimmune like Hashimoto's thyroiditis or any iodine deficiency. Total serum T3 measures total free and bound forms of T3. Normal ranges are 1.23 to 3.08 nanomoles per liter. If T3 levels are high, then it suggests hyperthyroidism. If they're low, it suggests hypothyroidism. T3 resin uptake. This test evaluates the amount of thyroid hormone binding globulin. Normal range is 25 to 35. If the range is more than 35%, it suggests hyperthyroidism. If it is lesser than or less than 25%, it suggests hypothyroidism. Next, free thyroxine index. This is the estimation of free T4 levels in the blood. It's a product of serum T4 and T3 resin uptake in percentage. Normal range is 3.5 to 8. If it is high, it suggests hyperthyroidism. If it is low, it suggests hypothyroidism. Now, serum protein bound iodine, it's an obsolete test. It is not very much used now because it measures the amount of iodine bound to proteins T3 and T4 in the bloodstream. Normal range is 4 to 8 mcg per dl. If it is high, it suggests hyperthyroidism, Graves' disease or iodine excess. If it is low, it suggests hypothyroidism, Hashimoto's thyroiditis or iodine deficiency. Free T3 test. This measures the amount of unbound T3 in the blood. Normal range is 2.3 to 4.2 picomoles per liter. If it is high, it suggests hyperthyroidism. If it is low, it suggests hypothyroidism. This is a reference table of all of these tests and their normal values. Now, tests of hypothalamic pituitary axis. In this, TRH is given IV in a normal individual at a dose of 200 picogram. In a normal individual, the interpretation is that the level of TSH in serum will rise from a basal level of 1 unit per ml to mean peak concentration of 10 units per ml at 20 minutes, and it returns back to normal in 120 minutes. But in hypothyroidism cases, the TSH level is found to be elevated, and in hyperthyroidism, there will be no response of a depressed TSH level. Main indications are in diagnosis of mild hyperthyroidism or Graves' disease. Uptake tests. These tests measure the amount of iodine which is absorbed by thyroid gland. There are two main uptake tests: radioactive iodine uptake test and technetium 99M pertectinate scan. Radioactive iodine uses iodine isotopes 131 and 123. These can be given orally, and a gamma camera measures the percentage of iodine absorbed by thyroid after 2, 4, or 24 hours. It helps in differentiating between different causes of hyperthyroidism, like Graves or Graves disease versus thyroiditis. Technetium 99 is administered IV, and the imaging is done very shortly after injection. It yields faster results than RAIU, that is why it's considered more beneficial. This is a figure that explains different levels of uptake in different pathologies. T3 suppression test is a diagnostic test used to evaluate autonomic thyroid activity. Normally, exogenous T3 suppresses TSH secretion, leading to reduced iodine uptake by the thyroid. But in autonomous thyroid tissue, the thyroid continues to take up iodine despite TSH suppression. Interpretation is, in normal thyroid function, exogenous T3 suppresses TSH, so there will be decreased radioactive iodine uptake. In autonomous thyroid function, despite T3 administration, this uptake remains high due to continued autonomous activity by the thyroid. Other miscellaneous tests are radiography, in which trachea can be seen whether it's displaced or narrowed. Chest X-ray can be done to see retrosternal goiter or metastatic changes. X-ray after barium swallow to see pressure effect and changes on esophagus. Bone scan can be done to exclude early bony metastasis. FNAC can be done as an out procedure since it's very quick. Ultrasound can be done to differentiate between solid and cystic swellings, and CT and MRI are yet in the experimental stages. Now, thyroid antibody tests, these two tests, anti-thyroid peroxidase antibody and anti-thyroglobulin antibodies, these are used to diagnose autoimmune thyroid disease and monitor CA thyroid after treatment. Basic interpretation is that if the antibody levels are high, they will give the evidence of autoimmune thyroid disorder. And if they are low or undetected, they do not negate the presence of any thyroid disease, but further evaluation has to be done to confirm the diagnosis. TSH receptor antibodies. This measures autoantibodies that either stimulate or block the TSH receptor on thyroid cells. If it is high, it confirms Graves' disease. If it is low, other thyroid tests are to be considered. So this is very basic interpretation of primary and secondary hypo and hyperthyroidism. In case of primary hypothyroidism, where the defect lies at the level of thyroid gland, T4 and T3 will be low and TSH will be high. Similarly, in primary hyperthyroidism, where again defect lies at the level of thyroid gland, T4 and T3 will be very high and TSH will be low. In secondary hypo and hyperthyroidism, where defect lies at the level of pituitary, TSH production will be low, and T4 and T3 will be low in secondary hypothyroidism, and TSH will be high, and T4 and T3 will also be high in secondary hyperthyroidism. This is TFT interpretation in hyperthyroidism. TSH is low and T3, T4 is high in all these three conditions: Graves' disease, thyroiditis, and or thyroid nodules. But TSI or thyroid stimulating immunoglobulin is positive in Graves' disease, and radioactive iodine uptake will be increased in Graves' disease. It will be decreased in thyroiditis, and there will be no TSI. And there'll be no TSI in thyroid nodules, but radioactive iodine uptake will be increased or normal. This is TFT interpretation of hypothyroidism. TSH will be increased in all of these three cases: Hashimoto's thyroiditis in early stage or Hashimoto's disease in later stage, and in pituitary abnormality. And T3, T4 will be decreased in all three, but antithyroid antibodies will be present in the autoimmune causes, which is Hashimoto's, and will be absent in pituitary abnormality. Thank you. So this was the...
Thank you, Kanupriya. That was a very concise talk about the investigations we need to do for a thyroid case. Now I would like to ask Dr. Seema Partani. to start her presentation. She'll be talking about the pre-medication and preoperative optimization of a thyroid case.
Thank you, ma'am. So without wasting time, I'm just going to start. My topic is the preoperative assessment and optimization in a patient presenting with thyrotoxicosis. The learning objectives of this lecture will be to know about the etiology, differential diagnosis, and clinical manifestation of thyrotoxicosis, along with thorough preoperative assessment, which includes history, physical examination, and investigations, preoperative preparation and optimization to ensure euthyroid state, and accordingly planning of treatment, whether it is elective or emergency surgery, and some treatment options in pregnancy. So we know the thyroid dysfunction is the second most common endocrine disorder in general population, and hyperthyroidism is a common condition with a global prevalence of 0.2 to 1.3% in iodine-rich areas, which can be increased in iodine-poor regions. Thyrotoxicosis and hyperthyroidism both are hypermetabolic states, but they are not synonymous. If we see, the hyperthyroidism is a biochemical diagnosis that is defined by an increase in the circulating thyroid hormone levels, while thyrotoxicosis is a clinical syndrome which is induced by multitude of disorders that causes the excess thyroid hormone and their inappropriate activities in different tissues, leading to a group of signs and symptoms. While thyroid storm is an acute life-threatening endocrine emergency, which resembling an exaggerated presentation of thyrotoxicosis. So if we, what are the different causes and differential diagnosis of thyrotoxicosis? Then one is the primary hyperthyroidism, which is the disease in gland itself. And the Graves' disease is contributes 60 to 70% cases of primary hyperthyroidism. Another is toxic multinodular goiter, toxic adenoma, functioning thyroid carcinoma with metastasis, activating mutation of the TSH receptors, tumor ovarian, that is the ectopic ovarian teratoma, and drug iodine axis. The secondary hyperthyroidism in which the excess of thyroid hormone is because of the stimulation of the gland, that is the TSH secreting pituitary adenoma, thyroid hormone resistance syndrome, chorionic gonadotrophic secreting tumors, or gestational thyrotoxicosis. Thyrotoxicosis may be without hyperthyroidism in whenever there is infection or destruction or inflammation of the gland. Subacute thyroiditis, silent thyroiditis, and other causes of thyroid destruction, including amiodarone, radiations, infarction of the adenoma, and ingestion of excess thyroid hormone, and even immune mediator that in carcinoma, we see immune inhibitors that also causes this. Now, Graves' disease or toxic diffuse goiter, which is the 60 to 80% cases of thyrotoxicosis, and prevalent in females, that is 7:1 ratio. In younger age group, that is 20 to 50 years of the age. This is an autoimmune disease. This is caused by the thyroid stimulating antibodies, which mimics the TSH receptors. And after binding with the receptor, activate the adenyl cyclase and stimulate the thyroid growth, vascularity, and secretion of the T3, T4. And in this, the gland is diffusely enlarged to 2 to 3 times of the normal size. If you look at the etiopathogenesis, that includes autoantibodies as an autoimmune disease, some genetic factors, cytokines are involved, and environmental factors including stress, smoking, increased iodine intake, postpartum. Another important cause is toxic multinodular goiter or plumber's disease, which is the multiple autonomous functioning nodules secretes excess thyroid hormones which are independent of the TSH. And it is usually seen in older patients more than 50 years. There may be excessive enlargement causing the pressure symptoms. And for the diagnosis, thyroid scan is done, which represents the hot nodules, and CT scans to rule out the malignancy. Toxic follicular adenoma is usually seen in around 1.5 to 18 cases in 1 lakh, in which the single autonomous nodule that secretes excess thyroid hormone and usually benign, but can lead to the clinical thyrotoxicosis. And there are some rare causes of thyrotoxicosis like hamburger thyrotoxicosis, in which the contamination of the ground meat by thyroid gland of animal. And it is usually suspected in community outbreaks or whenever the meat is prepared by inexperienced butchers. Apathetic hyperthyroidism, usually seen in elderly patients, which represents with fatigue, weight loss, depression, cardiac symptoms and usually mistaken for the age-related condition, but that should be looked for the hyperthyroidism. The factitious hyperthyroidism is very thyroid replacement medicines without the medical supervision with the goal of weight loss. And amiodarone thyrotoxicosis, that as we know, the amiodarone contains a significant iodine and it can induce an increased hormone synthesis and destructive thyroidectomy. So these are some terminologies. Now, how to diagnose a case of thyrotoxicosis? Focused assessment and clinical examination, imaging and spatial test, along with laboratory investigations, and a multidisciplinary approach is needed, including endocrinologist, cardiologist, radiologist, anesthetist, and surgeon. So for the focused history, including age, sex, occupation, residence, diet, and about the swelling, onset, duration, rate of the growth, whether associated with pain or fever. A rapid increase in the size of the swelling will indicate some hemorrhage inside the gland or the malignancy. The pressure effects, if on the trachea, it will represent dyspnea stridor. Dysphagia will show some maybe pressure on the esophagus, and recurrent laryngeal nerve will represent the hoarseness of voice. Whenever there is retrosternal extension, there will be dysphagia, dyspnea. Intratracheal extension, there will be dyspnea and hemoptysis. History of hemoptysis may be there. And very important history is sleepless nights of the patient in case of hyperthyrotoxicosis. And associated endocrine syndrome may be there. So history of autonomic nervous system dysfunction should be taken. After the history, coming to the clinical manifestations, the features may be common to the thyrotoxicosis and maybe some features may be specific to the Graves' disease. And overall, the clinical presentations depends upon the age, duration, severity of the disease, and individual responsiveness to the excess hormone. As we all know that thyroid hormones affects almost all the organ system of the body. That includes cardiovascular, increases the chronotropy and inotropy, increases the cardiac output, decreases the systemic vascular resistance, and afterload. That activates the renin-angiotensin system, resulting in sodium reabsorption and blood volume expansion, increasing the preload and resulting in the left ventricular hypertrophy and CHF. On the CNS, as we know, this hormone is essential for the development of CNS from embryonic stage to the adulthood. So development of visual auditory structure, cerebral regulation of the gait, all of the metabolism is affected by this hormone. If we see the musculoskeletal system, the muscle wasting due to the increased protein catabolism and hypermetabolic state of this. And low TSH is directly linked to the decreased bone mass and increased osteoporosis. So there are high chances of bone fractures may be there. On GI, the increases GI motility and increased peristalsis. So there may be diarrhea or increased frequency. Respiratory system, there is increased respiratory drive. The cellular metabolism is increased at respiratory level. So increased oxygen consumption and increased CO2 production may be there. And on reproductive system, they regulates the menstrual functions. So because as it affects all the organ systems, so the clinical signs and symptoms are also multiple. We see generally the weight loss instead of increased appetite, muscle weakness, heat intolerance, palmar erythema, and proximal vessel wasting along with the pretibial myxedema. CNS may we see the irritability, anxious, hyperkinesia, and tremors elicited in outstretched hands. We see the CVS cardiovascular systems are very, very important for anesthesiologist, and that includes the tachycardia, palpitation, hypertension, breathlessness, tachyarrhythmias, and especially atrial fibrillation in elderly patients, and there may be features of the cardiac failure. GI, there will be increased appetite, vomiting, diarrhea. A genitourinary system, there will be history of oligomania or loss of libido, and eye signs in Graves' disease. So these are the symptoms and signs. It's just a look, it's a decreasing order. The most common symptoms of CNS in primary thyrotoxicosis, and the sign is tachycardia, atrial fibrillation, and these are the decreasing descending order. Some other signs like thyrotoxic cardiomyopathy, which is characterized by the lymphocytic and eosinophilic infiltration of myocardium with fibrotic and fatty changes. And usually elderly patient, whenever it comes with unexplained cardiac failure or arrhythmias, they especially atrial arrhythmias, they should be evaluated for the thyrotoxicosis. And thyrotoxic periodic paralysis, which is rare and life-threatening complication, and usually triad of muscle weakness, acute hypokalemia, and thyrotoxicosis. And if suspected, should be treated with low dose of potassium and beta blockers to avoid the arrhythmias and improve the muscular function. Now, some features which are specific to the Graves' disease, we know triad of Graves' disease, ophthalmopathy, dermopathy, acropathy. Ophthalmopathy is, just to remember, there's pneumonic, the L specs, that is upper eyelid retraction, the soft tissue involvement, there's a proptosis, involvement of extraocular muscles, corneal involvement resulting in ulceration, and sight loss due to the optic nerve involvement. And dermopathy, though rare, less than 5% of the patients, but usually the pretibial myxedema in case that is a non-inflamed indurated plaque, and the shin, anterior aspect of the tibia, there will be deep pink to purple, and that will give the pudgy orange, like orange skin appearance. And in acropathy, there is a digital soft tissue involvement, and clubbing is seen in the nails and the toes, and it is less than 1% of the patient, and it's usually seen with the ophthalmopathy or dermopathy in late cases of the Graves' disease. Some important eye signs we usually see and during the case discussions also, that is the absent forehead creases on superior gaze, that is Joffrey's sign, upper eyelid lag on downward gaze, that is Von Graffi's sign, and will elicit the lid retraction with the scleral show, this Dalrymple signs. Whenever some pen, the tip of the pen is put in between the eyebrows and ask the patient to converse. So there will be deficiency of converse, and that is a Mobius sign. When there is lower lid lag on upward gauge, as seen in this picture, that is Griffith's sign. And most important is thyroid ophthalmopathy, that is a combination of bilateral exophthalmos, lid retraction, shear, and enlarged thyroid. So these are the typical signs we elicit in the cases of Graves' disease. Now, after this, the general physical examination overall of a hyperthyroid patient, we see usually thin and underweight with wasting of muscles, facial expression of excitement, tension, nervousness, agitation with or without variable degree of exophthalmos. And these patients usually sweats a lot, and hot and moist palm you can see. Most important for anesthetist is airway examination, assessment of neck movements, thyromental distance, Muller-Patti grading, alignment of teeth. Whereas the difficult intubation is always predicted in these type of cases. And if we see the pulse rate is rapid, may be regular or irregular. The most important index is sleeping pulse rate. The degree of thyrotoxicosis can be seen that mild, less than 90, moderate, 90 to 100 beats per minute. But if it is more than 110, then it means there is severe thyrotoxicosis. So overall, if we see the primary thyrotoxicosis, the burnt of attack is the central nervous system, and in secondary, the burnt of attack is the cardiovascular system. Local examination, normally thyroid gland is not visible. To make it prominent, the Pigelos method, in which they place the hands behind the head and push the hand backwards against the clutch hand. So this will be prominent, and you can see the uniform swelling or isolated nodules of different sizes. Thyroid swelling moves upwards on deglutition, while thyroglottal cyst moves upwards, also moves upwards, but on protrusion of the tongue. Some methods of palpations, the gland can be palpated from behind or from the front with the neck slightly fixed. If we are behind, put the both hands on the neck, and with the 4 fingers, each hand are placed in each lobe and the isthmus. And this is the way we can palpate easily. And important is assessment of the margins of the thyroid gland, particularly the lower margins. And Lay's method, from the front, if the normal lobe of the thyroid is pushed to the side of the nodule so that the solitary nodule can be made prominent and palpated well. Trials method, placing the thumb on the thyroid gland and asking the patient to swallow. The small thyroid nodules within the thyroid gland can be palpated by this method. Whenever there is suspicion of obstruction, the pressure on the thyroid lobe against the trachea, it will produce a stridor. This is Kocher's test. Absence of carotid pulsation on inspection and palpation. It suggests some malignancy which encasing the carotid and masking its pulsations is known as the Berry sign. And whenever the bruit heard over the closed eye by stethoscope in Graves' ophthalmopathy is Reisman's sign. Now, very important for us, how to assess the retrosternal extension of the thyroid mass. There are the Pemberton sign. Ask the patient to raise both the hands over for a while. The congestion of the face and distress become evident in case of retrosternal goiter due to the obstruction of the great veins at the thoracic inlet. And in this, we can't get below the swelling on palpation. On percussion, there will be dull note, which will suggest the retrosternal extension. And on auscultation, in general, the bruit will be heard over thyroid gland when there is large mass. After the examination local, now coming to the investigations part, what investigation we should plan. The routine blood investigation includes CBC, the total serum calcium level, electrolytes, blood sugars, alkaline phosphate, all investigations we routinely do along with the urine test. Chest X-ray is very important along with the AP and lateral view to see the deviation and compression of the trachea, barium swallow to see the pressure effect, if any, on the esophagus. Routine ECG can show the tachycardia, tachyarrhythmias. Echocardiography is very important to see the left ventricular functions. CT scan to show the terror. Whenever there is maybe some airway compromise, then should go for this to know the tracheal narrowing or detect the tracheal invasion. Thyroid scans to rule out the DD karna hai. So just for Graves' disease, the toxic or hot nodules can be seen, and USG to evaluate whether the cystic swelling or the solid swelling. Indirect laryngoscopy pre-operative usually by the ENT specialist to document the vocal cord function is very, very important for us. And respiratory flow volume, though rare and not routinely done, but may give a clue for the fixed airway obstruction or extrathoracic and intrathoracic obstruction. Laboratory diagnosis discussed by Dr. Kanupriya. We know how to diagnose by the TSH, T3 and T4 a case of hyperthyroidism. So I will not discuss much about this. The overall evaluation of thyrotoxicosis will measure the TSH and free T4. And if TSH is low and free T4 is high, then it is primary thyrotoxicosis, and then look for the features of the Graves' disease. And if TSH is low and T4 is normal, then measure the unbound, that is free T3. And if T3 is high, then it is T3 toxicosis. And if it is normal, then it is subclinical hyperthyroidism. Then follow the patient, if subclinical, 6 to 12 weeks further. But another situation when TSH is normal or increased T4, and it is a secondary hyperthyroidism in which the TSH secreting pituitary adenoma may be there. And TSH and T4 both are normal, then no further test is required. If it is Graves' disease, features of the Graves, that is triad, then it's Graves' disease. But if it's not, then it may be multinodular goiter or toxic adenoma. If that is for, we'll go for the scan or radioiodine uptake. If it is hot nodules, maybe toxic. And if it is low iodine uptake, then maybe destructive thyroiditis. And if it is not, then rule out the other causes, including stimulation of the chorionic bronchitis. So this is how overall, based on the lab investigation, we will evaluate a case of thyrotoxicosis. Now it's very important. There is diagnostic tools to anticipate the thyroid storm. The one tool is Birch-Warskovsky point scale, which was introduced in 1993. In the scoring system, some points are given for the following manifestations like temperature, CNS dysfunction, tachycardia, presence of atrial fibrillation, heart failure, GI dysfunction, and presence of precipitating factors. And after scoring, if the score is more than 45, it highly suggests thyroid storm. 25 to 44 supports the diagnosis. And if it is less than 25, the diagnosis is unlikely. So this is the scoring system. Which different points are given, different gradings. And again, another tool is Akamizu diagnostic criteria given by Japanese Thyroid Association in 2018. And different diagnostic components for the thyroid storm are CNS manifestations, which include the restlessness, delirium, psychosis, lethargy, convulsion, and coma. Some non-CNS manifestation, including fever greater than 38 degrees Celsius, tachycardia whenever the 130 beats per minute, including tachyarrhythmias, CHF features, and GI and hepatic features are there. So, to diagnose the various combination, whether it is definitive thyroid storm or suspected thyroid storm. For the definitive, one combination is the elevated thyroid hormone along with one CNS and one non-CNS manifestation. And maybe the raised thyroid function with only 3 or more non-CNS manifestations. So these are the two combinations which suggest the definitive thyroid storm. And in suspected, there will be history of thyroid disease, there will be ophthalmic goiter, but thyroid function levels are not determined. So after these diagnostic tools, we should consider the triggers for the thyroid storm pre-operatively so that we can reduce the incidence in intra or post-operative period. So general triggers are non-thyroid surgery, trauma, history of trauma, infection, pulmonary embolism, history of AMI, diabetic ketoacidosis, and in pregnancy, it's very important, preeclampsia, parturition, and hyperemesis gravidum, they trigger the thyroid storm. And thyroid-related triggers are thyroid surgery, whenever there is abrupt discontinuation of the anti-thyroid medications, overdose of thyroid hormone, whenever there is acute iodine load in form of radioactive iodine treatment, contrast dye, oral iodine. So these all are the triggers which should be considered pre-operatively. So thyroid still is a historical term obsolete nowadays, and just to prevent the pre-operative stress of surgery which could lead to thyroid storm, I will not in detail. Now for the optimization, what should be the treatment approach? What are the goals for the optimization of a hyperthyroid thyrotoxic patient? First is rapid amelioration of the symptoms and decreasing the thyroid hormone synthesis. So the goal is to achieve the euthyroid state. In symptom control, the most important is beta blockers. Propranolol is a drug of choice, 20 to 40 milligram, or atenolol, 25 milligram, or calcium channel blockers. And relief from sympathetic overactivity is important. Decrease thyroid hormone synthesis by anti-thyroid drugs, radioiodine, and surgery. Now coming to the beta blockers. Beta blockers, there is upregulation of thyroid hormone beta receptors. So it blocks the beta receptors and provide the symptom relief from tremors, palpitation, anxiety, heat intolerance. Decrease heart rate. The heart rate is stabilized, and cardiac output and oxygen consumption in thyrotoxicosis. The drug of choice, propranolol, 40 to 80 milligram per day. It's important, it has a very short life and requires multiple doses per day. And high doses, the benefit of propranolol is high doses, that is 40 milligram QID, inhibits the peripheral conversion of T4 to T3. So it's very important for thyroid storm. But it is contraindicated in bronchial asthma, COPD patients. So selective atenolol, that is 25 to 100 milligram per day, it is long acting and twice daily can be used. Now coming to the classification, to start antithyroid drugs, we should know about how it acts. Inhibiting the thyroid hormone synthesis, that is antithyroid drugs, propylthiouracil, methimazole, carbimazole. Inhibit the iodide trapping, that's perchlorides. Inhibit the hormone release, iodides, and destroy thyroid tissue by radioactive iodine. So if we know the mechanism, we can just see that how thionamides work. Thionamides are first line treatment, that is carbimazole, methimazole, and propylthiouracil. Doses are 15 to 40 milligram for carbimazole, 10 to 30 milligram per day for methimazole, and propylthiouracil is 100 milligram every 8 hours. Carbimazole is a prodrug, it changes into methimazole. Doses are titrated to response. So for that, investigate for the free T3 and T4 every 3 to 4 weeks till control is achieved, and maintains dose in the form 2.5 to 10 mg for methimazole and 15 to 100 milligram for PTU daily. Now, if we see the methimazole is a drug of choice because it has a better safety profile and better compliance because it has a longer half-life, that is 6 to 9 hours. So given in OD or maybe BD doses. And there is a decreased risk of hepatotoxicity in children. So drug of choice in children. But it increases the vascularity of the gland. So in preoperative preparation on the day of surgery, it is not recommended the carbimazole. Propylthiouracil has a shorter half-life, required multiple doses. But the benefit is that is a less teratogenic, so it is preferred in first trimester of pregnancy. And another benefit is reduces the peripheral conversion from T4 to T3, so preferred in the thyroid storm. But the side effects are more, higher incidence of nephritis, vasculitis, and agranulocytis on long-term use. If you see iodides, fastest acting thyroid inhibitor, decreases all phases in high doses, but mainly it decreases the release from the of thyroid hormone. That Wolff Chekhov effect is a transient phenomenon. Whenever iodide is given, the effect starts within 24 hours of iodide intake, and it reaches its maximum effect around 10th day of the treatment. This is a decrease in the hormone. But after the 10th day, there is escape of this phenomena, and the iodine starts to be used to the hormone protection. So this is known as a Jod-Bestos effect. And iodine, what is the importance? It reduces the size and vascularity of the gland. So it is reserved for preparation of the hyperthyroid patient for the surgery, managing the patient of actual or impending thyroid storm, and treating the patient with severe thyrocardiac disease. How to administer, it's very important, how to prepare, how to administer the glucose iodine, saturated solution of potassium iodide. So saturated solution of potassium iodide is 1 to 2 drops, TDS. Glucose iodine is the 5% solution, which contains the 5 gram of iodine and 10 gram of potassium iodide, and make a mixture to 100 ml. We give 5 to 7 drops TDS. Each drop of Lugol's iodine contains 8 milligram of iodine, and each drop of the saturated solution contains around 35 to 50 milligram of iodine. And these iodines can be mixed with water or fruit juices for oral administration, and if it is not possible to give orally, diluted with water and can administer via rectal route or nasal route, nasogastric tube. Now, oral iodine-based radiographic dyes, like we know radio contrast dyes, iodate, hyaluronic acids are also used for the preparation of these patients, have beneficial effects. They also inhibit the peripheral conversion of T4 to T3, and in emergency, sodium iodide can be given 1 gram IV eternally. But for these iodates, to start the iodates, always remember the anti-thyroid drugs should precede the initiation of thyroid, as iodide alone may exaggerate the thyroid status. So these are the adverse effects of anti-thyroid already discussed, the minor and the severe agranulocytosis, neutropenia, thrombocytopenia, vasculitis, nephritis. So this is the overall about these drugs, the doses, mechanism of action, and the side effects. The another drug, lithium carbonate, it also inhibits the synthesis and release of the thyroid hormone. It is an alternative treatment of thyroid storm and rapid preparation of the thyroidectomy. Patients who are allergic to iodides, given 300 milligram orally for 6 hours, but whenever you are using lithium, always keep serum lithium level concentration check, and it should be maintained within the range of 1 milliequivalent per liter. Another drug called styramine, which is an bile acid sequestrant. It is an ion exchange resin which inhibits the enterohepatic circulation of the thyroid hormone. We know that the circulation of thyroid hormone is increased in thyrotoxicosis. So it is quite effective in rapid reduction of the thyroid hormone. It's given 4 grams 2 to 4 times a day. So these are the alternative treatments. Steroids, very important. High doses reduces the peripheral conversion of T4 to T3. And in Graves' disease, decreases the serum T4 concentration by direct action on the gland or reducing the thyroid stimulating immunoglobulins. Another, if the benefit is remove the risk for the adrenal insufficiency that is associated with thyrotoxicosis. Doses, hydrocortisone 100 milligram orally or IV 8 hourly, 2 mg dexamethasone orally or IV 6 hourly, 0.5 milligram of betamethasone orally IM IV, and administer the IV. Now, another perchlorates or ionic inhibitors, they are also important, especially in the amiodarone-induced thyroiditis. They also used in the preparation of the thyroid surgery. Iodine ablation therapy. This is indicated whenever there is a patients more than 40 years, and especially those who fails to respond to the anti-thyroid drugs and failure of surgery, but contraindicated in pregnancy and lactation. Iodine 131 capsule emits gamma radiation which ablate the thyroid gland. Dose 185 to 555 MBQ, but the complication is hypothyroidism, infertility, and secondary cancers. Subtotal or total thyroidectomy surgery is very, very important for the prompt control of the disease. Lower incidence of hypothyroidism than ablation therapy. Thyrotoxicosis is corrected in more than 95% of the patients by the surgery, and mortality is less than 0.1%. Therapeutic plasma exchange is another modality by the American Society of Apheresis in 2019 in patients with contraindication to the other therapies. In this, the multiple session of TP is given, which lower the thyroid hormone level, reduces autoantibodies binding proteins, cytokines, and catecholamines in Graves' disease. Something about the hyperthyroidism in pregnancy. As anti-thyroid drugs crosses the placenta and can cause a fetal hypothyroidism, it is treated with a very low doses of the anti-thyroid drugs. Propyl thyroxine, I already discussed, it's preferred and it's given 200 milligram per day. If higher doses of PTU is required, that is more than 300 milligram per day, then thyroidectomy should be performed in second trimester. And thyroid storm is managed as same way as in non-pregnant patients. And we know the incidence of thyroid storm is more in pregnancy because of maybe some preeclampsia, the parturition, and hyperemesis gravidarum. This crossing is come, what lines are coming on this my screen? I don't know. The choice of treatment options are treatment for optimization depends upon the men. These are all options. Now, how to go ahead? It all depends on the factors like age, underlying etiology, severity of the symptoms, comorbid condition, pregnancy planning, patient preferences, access to the treatment, and what are the side effects of the treatment. Each option have its own advantage and disadvantage, and we should be discussed with multidisciplinary team and patient and plan accordingly. If it's an elective surgery, cancel the procedure, optimize the patients for 12 to 18 months or till become euthyroid. Psychological reassure and counseling is very, very important in these patients. Start the propyl thiouracil 150 to 200 milligram orally initially, and then 100 to 150 milligram titrate based on the patient condition. The second choice is carbimazole 10 to 40 milligram orally. Then beta blockers, propranolol 10 to 40 milligram orally or atenolol 25 milligram initially, and then titrate to 12.5 milligram based on the response. Until the resolution of adrenergic effect, the targeted, the heart rate should be less than 80. Or there may be, if the contraindication of these blockers, then we can consider for the calcium channel blockers. The important, the guideline says we should supplement calcium and vitamin D in this optimization period to prevent the post-operative hypocalcemia because of parathyroid injury may be there. After this, follow the status of the patient, initially 4 to 6 weeks, then 3 months, at 6 months and 1 year interval in consultation with the endocrinologist. After the control sign and symptoms, the laboratory finding in the normal range, patient is euthyroid, proceed for the surgery and anesthesia. If not control, then defer for optimization, recheck for the antithyroid regime and rule out the reasons for the uncontrolled thyrotoxic and act accordingly. But if it is an emergency, then what next? Take full history and physical examination with the multidisciplinary approach. Cardiovascular stability is very important in emergencies. Always start beta blockers, propranolol IV, 0.1 to 0.15 milligram, or may be given 40 milligram orally 3 to 4 times. We can start esmolol if propranolol is not, then 50 to 100 microgram per kg per minute, or whenever there is condition when they are contraindicated, start usually metoprolol 25 to 50 milligram orally or 2.5 to 5 milligram intravenous every 5 minutes, repeat as needed up to the 15 milligram. And it can be given in asthma or COPD. Then start antithyroid drugs, that is propyl thiouracil 200 milligram orally every 4 to 6 hours, or carbimazole, or glucose iodine is very important in emergency if we have 7 to 10 days, 5 to 7 drops, TDS, prior to surgery. If we do not have much time, even though we should start the iodine at least 1 hour after the antithyroid treatment. It will help to prevent the thyroid storm. Hydrocortisone 100 milligram every 8 hours or dexamethasone 2 milligram every 6 hours should be started and tapered 72 hours post-operatively. Diazepam 0.1 to 0.3 just for the calming, or we can use a midazolam. For the rapid preoperative preparation, whenever we see that thionamides are there, sufficient time is not there, or there is serious side effects with thionamides, or patient is non-compliant with these drugs, then combination of Lugol's solution, we say it is said that 13 drops TID along with dexamethasone 2 milligram BD and beta blockers adjusted to achieve the heart rate less than 80, the surgery can safely be performed in these conditions. We see criteria for euthyroid, laboratory criteria and clinical criteria. The laboratory TSH 33T4 should be within normal limits, and clinically patient should be, there is no sign and symptom of hyperthyroidism, heart rate should be stable, stable weight, the feeling of well-being, normal energy level, healthy skin, nails, and no heat and cold intro. So we should look for the euthyroid state of the patient before that. So take-home message for preoperative assessment and preparation is, the thyrotoxic patients may present with unique set of challenges to anesthesiologist. Thorough preoperative assessment to reach a definitive diagnosis is essential. Adequate preoperative preparation and optimization to get euthyroid state is required to mitigate the adverse events. For elective surgery, plan accordingly, optimize for 12 to 18 months if permissible, or till the patient become euthyroid. But if it an emergency, optimize with recommended combinations of the drug. Always consider triggers for thyroid storm. And very important, a multidisciplinary approach is essential to reduce the perioperative morbidity and to achieve the better patient outcome. Thank you.
Thank you, Dr. Seema, for that comprehensive lecture about the preoperative preparation of a thyrotoxic patient. And now I would request Dr. Alka to share her slides about management of a thyrotoxic patient for thyroid surgery.
Am I
Yes.
audible?
Yes.
So, Seema ma'am has already pre-optimized the patient. So we'll directly come to anesthetic management of a thyrotoxicosis patient for thyroid surgery. The learning objectives of this class would be to know the anesthetic concerns in a patient with hyperthyroidism. What are the anesthetic techniques and airway management in case of large thyroid swelling? The drugs that are used in hyperthyroidism, intraoperative monitoring, extubation strategies, intra-op and post-operative complications, and thyroid storm and with its management. Now, thyroidectomy is the commonest endocrine surgical procedure, and when a patient with hyperthyroidism comes for thyroidectomy, it poses a unique challenge to the anesthesiologist. So, proper perioperative assessment, preoperative optimization, and anesthetic management is crucial to minimize intra and post-operative complication. Now, it is also complicated by airway problems, which should be managed with utmost care in the post-operative period. Thyroid storm, it is a life-threatening complication that may occur perioperatively if the patient is with uncontrolled hyperthyroidism or in case of precipitating factors. Now, the indications of thyroidectomy is in the patients of Graves' disease, toxic multinodular goiter, adenoma with hyperthyroidism who were unresponsive to the medical management, goiter with obstructive symptoms, or the presence of retrosternal goiter in absence of obstruction, proven or suspected thyroid malignancy, recurrent hyperthyroidism, poor compliance of the patient, and for the cosmetic reasons. Now, the anesthetic concerns whenever the patient comes with hyperthyroidism includes, now this hyperthyroidism is a hypermetabolic state, so it has potential impact on the anesthetic care and perioperative outcome. Perioperative hemodynamic instability may lead the patient to trachearrhythmias and also the coronary spasm, and in the future, the cardiomyopathy may occur. Because of the respiratory muscle weakness, the patient have chances of post-operative mechanical ventilatory support after general anesthesia. Airway may be compromised because of large goiter, and some bleeding abnormalities may occur because of decreased platelet counts. The patients who are on anti-thyroid drugs, it takes several weeks to become euthyroid, and hence the chances of perioperative thyroid storm increases. On the other hand, the beta blockers, although they are cardioprotective, but overzealous treatment may cause congestive heart failure, bronchospasm, hypoglycemia in diabetic patient. And failure to achieve euthyroid status, intraoperatively the doses of anesthetic agents increases, and there is chances of atrial fibrillation and again thyroid storm. So there should be anticipation and preparation for managing such post-operative surgical complications. Now, the primary goal is to ensure the euthyroid status whenever the patient is coming for thyroid surgery, managing the potential difficult airway, decreasing the stress response conditions, avoiding the drugs that cause sympathetic hyperactivity, maintaining the deep plane of anesthesia, and always reserve an ICU bed because they may land up into the thyroid storm. Preoperative orders includes the informed written consent for post-operative ventilation as well as tracheostomy. In case of emergent procedures, the rapid preparation is required, which will preclude waiting for the euthyroid state, and continue antithyroid drugs and beta blockers up to the day of surgery. Advise NPO status as per standard guidelines, give anti-aspiration prophylaxis, and anxiolytics and sedatives are prescribed only if the airway is not compromised. OT preparation on the day of surgery includes difficult airway trolley, which always consists of rigid bronchoscopy with an ENT surgeon, tracheostomy and cricothyrotomy kit. All the measures that are taken for cooling and thyroid storm should be available. Along with it, emergency crash car, the drugs that are used in thyroid storm, and also the vasopressors and the phenylephrine for the hypotension. Now, there are various anesthetic techniques, that is general anesthesia, which is routinely used, supraglottic airway device, cervical epidural anesthesia, or blocks like superficial and deep cervical plexus block. But the choice of anesthetic technique is general anesthesia with endotracheal tube and controlled ventilation. Now, the airway concerns if the patient is coming with a large thyroid swelling includes tracheal deviation, compression, or invasion because of carcinoma. Tracheomalacia that may occur because of long-standing goiter. It may lead to postoperative airway collapse, worsening of compromised airway in supine position when now we are inducing the patient because of loss of spontaneous breathing and paralysis. Retrosternal extension may obstruct the major airway and cardiovascular structures during induction. Vocal cord palsies and impaired airway reflexes land up into aspiration and stridor postoperatively, and tracheostomy and cricothyrotomy are sometimes impossible in these patients. Now, the pre-oxidation should be 100% with oxygen for 3 to 5 minutes to achieve the end tidal O2 of more than 90%, because these patients have increase in metabolic rate and oxygen consumption. And in case of hypoxia, it may stimulate the sympathetic nervous system. Cautious use of sedatives to prevent anxiety. Avoid anticholinergics like atropine because it causes tachycardia and alteration in the thermoregulation. Shorter acting opioids are safer to use, and dexmedetomidine can also be used because it decreases the dose of opioid and anesthetic agents intraoperatively. Now, if the swelling is small and there is no evidence of tracheal compression or a deviation, then IV induction agents with conventional or assisted video laryngoscopy assisted endotracheal intubation can be done, but always confirm bag mask ventilation before giving neuromuscular blockade for intubation. But if the swelling is large and there is evidence of compression and deviation, and there is no retrosternal extension, inhalational induction is preferred with keeping the patient on spontaneous respiration and avoiding any muscle relaxant. And induction can be done in lateral position or semi-recumbent position. And in case of whenever the swelling is compressing the trachea, lifting of the swelling can be done, and standby fiber optic bronchoscope can be kept ready. But along with, if in case of large swelling and there is severe tracheal compression with retrosternal extension and the patient has airway compromise and signs and symptoms, stridor and wheezing are present, then directly go for awake fiber optic bronchoscope, and standby rigid bronchoscopy with ENT surgeon should be kept ready. So if we are not able to pass a bronchoscope of beyond the narrowing of the trachea, then rigid bronchoscopy could be used. And always remember that fiber optic bronchoscope may cause complete airway obstruction because we cannot negotiate the narrowing of the trachea, and in that case use of pediatric fiber optic bronchoscope can be used. If you are not sure and that the large thyroid mass for intubation, always use a controlled tracheostomy with the use of veno-venous ECMO. That should be done prior to induction for the rescue to rescue the airway in that cases. Now, IV induction agent thiopentone is considered an induction agent of choice because it prevents the peripheral conversion of T4 to T3. Propofol is safe to use because of its rapid onset, rapid recovery, and having anti-emetic property. But if it is used in maintenance, that is TIVA is used, it has been shown that the infusion rates are increased because of the increased clearance and volume of distribution in these patients. Etomidate can be used in hemodynamically unstable patient, and avoid ketamine because it causes sympathetic overactivity. Now, the induction should be done always slow because of the hyperdynamic circulation. Conventional endotracheal tube may cause kinking during long surgical procedures, and it is preferable to use flexometallic endotracheal tube. Other alternatives are RAE North Pole endotracheal tube, and if there is presence of a tracheal compression, smaller size of endotracheal tube should be used, and avoid overinflation of a tube cuff to prevent the tracheal mucosal injury in these patients. Whichever endotracheal tube is used, it should be advanced beyond the point of extrinsic compression, and the intubation should be smooth within 15 seconds, and always prevent the pressure response of laryngoscopy and intubation with various drugs that can be used. Now, supraglottic airway devices can be used if the surgeon is comfortable and the swelling is small. The added advantages of supraglottic airway includes that it can be used for ventilation in difficult situation, and it has less coughing during emergence, and it can be used for the visualization of vocal cord movement and through via the fiber optic bronchoscope. But the disadvantages are that risk of dislodgement during the positioning and thyroid manipulation. Airway may compromise if the tracheal deviation and compression and there is retrosternal goiter, and its role is doubtful in carcinomas. The position that is given for thyroid surgery is known as rose position, in which the patient is felt supine with head elevated. Occiput is rested on the head support. Neck is extended with the sandbag under the patient's shoulder. The arms are adducted at the sides, and eyes are protected in case of exophthalmos or proptosis. Care should be taken to avoid the suspended head and avoid hyperextension at the shoulder joint because that may cause stretching of the brachial plexus. Ensure feasible use of IV extensions and rule out any cervical spine disease preoperatively for safety of neck extension. The goal of maintaining anesthesia is to avoid the drugs that cause sympathetic stimulation and to provide the sufficient depth of anesthesia to avoid the exaggerated response to the surgical stimulus. All muscle relaxants as such are safe except pancuronium, but if you are using suxamethonium in case of difficult intubation, it should be cautiously used, and alternatively rocuronium can be used for intubation as well as maintenance, but vicuronium is a preferred drug because it is cardiostable. The dose should be titrated in case of hyperthyroidism because the hyperthyroidism may have coexisting neuromuscular disease like myasthenia gravis and thyrotoxic myopathy. Volatile anesthetic agents, it requires increased concentration due to increase in cardiac output, but there is no significant change in the MAC values. And sevoflurane is preferred over isoflurane and desflurane because desflurane causes tachycardia and excitability. So sevoflurane is preferred. Intraoperatively, maintenance can be done with Tiva, propofol, and remifentanil infusions, and the meticulous fluid management should be done and maintaining normothermia, preventing hypoxia and hypercarbia because all these causes increase in sympathetic nervous system activity. The drugs that should be avoided are ephedrine, epinephrine, noradrenaline, and dopamine, and also ask the surgeon to avoid local anesthetic with using adrenaline because it will cause tachycardia and disturbance. Intraoperative monitoring includes standard physiological monitoring in the form of ECG, NIBP, SpO2, EtCO2, temperature, and urine output. Advanced monitoring and in the form of invasive monitoring is done in case the patient has a history of CHF, thyroid storm, or hypotension, or any cardiac associated comorbidities. Additionally, neuromuscular or respiratory gas monitoring can be done, and recently intraoperative nerve monitoring for finding out the recurrent laryngeal nerve injuries, if available, can be done. Now, intraoperative complication may occur in the form of accidental extubation, displacement, kinking of the endotracheal tube while positioning and while manipulating the thyroid drug. Bradyarrhythmias may occur because of carotid body stimulation, excessive bleeding because of vascularized gland and vicinity of major vessels. There may be chances of nerve injuries, air embolism, and thyroid storm. So precautions that could be taken before extubation in thyroid surgery includes there should be minimal airway irritation and preventing cough and bucking so as to during emergence. So administer the drugs that prevent this, like Dexam, lidocaine, or remifentanil can also be used. Ensure complete reversal of neuromuscular blockade. Assessment of vocal cord movement can be done with conventional laryngoscopy or video-assisted laryngoscopy and fiber optic bronchoscopy, and USG-guided vocal cord movement can be seen. Assess the airway patency. Preparation for reintubation should be done if needed. Ensure that surgeon is available in case of airway obstruction. Avoid sympathetic stimulation. Monitor for hemodynamic and thyroid storm signs and symptoms, and observe for post-extubation respiratory distress. Now, there are various techniques that can be used for extubation. One is Bailey's maneuver, that is substituting the endotracheal tube with supraglottic airway when the patient is paralyzed, and then removal if the patient is on spontaneous breathing. Now, flexible fiber optic bronchoscope can be used that can be inserted through the supraglottic airway to visualize the vocal cord movement. or airway exchange catheter is used in case of large goiter with a difficult intubation, and that can be used for conduit for re-intubation also. But if you're not sure of immediate airway patency after extubation, always shift the patient to ICU and plan for planned extubation should be done in ICU after the extubation criteria is completed by this patient. Post-operatively, prophylaxis for the nausea, vomiting to be done to minimize the risk of wound hematoma during retching and vomiting. Multimodal analgesia for post-op analgesia, which includes various drugs, NSAIDs and opioids, infiltration of wound site, and also USG-guided superficial cervical plexus block can be administered. Keep a suture removal scissor along with the patient if needed in case of hematoma, and continue beta blockers and stop anti-thyroid drugs post-operatively. In some higher centers, the thyroid surgery is done under cervical plexus block and cervical epidural block. And superficial cervical plexus block is the technique of choice because deep cervical plexus block is difficult to perform, is less effective, and it is related with more anesthesia-related complications like vertebral artery puncture, dural puncture, and bilateral phrenic nerve blocks. The advantage being that it can be used in a large goiter with difficult intubation and in hemodynamically unstable cardiac patients. And also it allows the intraoperative voice monitoring and reduces the length of stay and cost of the hospital. But it is contraindicated if the surgery is planned for sternotomy or lateral neck dissection. If the patient has cervical lymphadenopathy or locally invasive cancer, the patient is allergic to anesthetic drugs, and if the patient is refusing for local regional block. Post-operative complication in the form of respiratory distress or airway obstruction can occur. The earliest causes are wound hematoma, recurrent laryngeal nerve injury, tracheomalacia, laryngeal edema, pneumothorax, and later hypoparathyroidism causing hypocalcemia, causing laryngospasm, and superior laryngeal nerve palsy can occur. And another is life-threatening thyroid storm that may occur intraoperatively as well as postoperatively. Neck hematoma, that is because of venous lymphatic congestion of airway structures leading to obstruction and edema rather than direct compression of trachea. It may occur within 6 hours postoperatively, and it can be prevented by checking the hemostasis before extubation by Valsalva maneuver and avoiding the cuffing and retching post-extubation. Management includes the removal of sutures immediately bedside, head-up position to lower the venous pressures, nebulization with epinephrine, and systemic steroids are given if associated laryngeal edema. But definitive hemostasis requires emergency surgical evacuation, and no delay for intubation should be done because later the intubation is performed, the more difficult it becomes due to the enlargement of hematoma. Nerve injuries may occur because of traction, transection, entrapment, ischemia, and that is usually seen in large goiters if the patient has operated for malignancy or re-exploration. Now, recurrent laryngeal nerve, that may be temporary or permanent, unilateral or bilateral, partial or complete. And it is seen that in partial injury, the abductor fibers are first affected as compared to adductor fibers. So recurrent laryngeal nerve may be unilateral and bilateral, but the unilateral injury partial is asymptomatic and complete causes hoarseness of voice. Bilaterally, the dreaded complication is partial bilateral recurrent laryngeal injury because it causes severe respiratory distress or stridor post-operatively, and the patient requires immediate re-intubation, and sometimes tracheostomy is required in long-term cases. On the other hand, superior laryngeal nerve, the motor part only causes voice alteration and voice fatigue, and if sensory is affected, it causes the deranged swallowing and dysphagia in these patients. So now there's recently intraoperative recurrent laryngeal nerve monitoring can be done with the use of a EMG tube to detect the recurrent laryngeal nerve activity. But there are some anesthetic consideration if we are using this monitoring in the former that avoid usually long-acting neuromuscular blockades are avoided. Use of shorter acting neuromuscular block, that is dexamethasone, can be used for intubation Or alternatively, minimal dose of rocuronium can be used for intubation, which can be reversed with the sagamatics before monitoring is indicated. On the other hand, if you don't want to give neuromuscular blockade, remifentanil intubation could be done along with propofol. And ensure correct placement of the tube between the vocal cords with a midline position, and it should be confirmed by laryngoscopy. DWASH is preferred as compared to inhalational agents to maintain the optimal signals. And if volatile anesthetic agents are used, it should be used at less than 1 mAc to avoid signal suppression. Avoid local infiltration near the nerve because it may mask the nerve injury. And during neck extension or positioning, the electrode may move and out of correct position related to vocal cordia. So always check laryngoscopy should be done before starting the surgery. Tracheomalacia, that is seen in long-standing goiters causing airway obstruction and post-extubation stridor. And diagnosis can be done by the surgeon by the intraoperative assessment as a soft floppy trachea, or before extubation, cuff leak test can be done. That is leak after deflating the cuff while the tube is in situ, and the leak volume of less than 110 ml or less than 10% of delivered vital is diagnostic, is indicative that tracheomalacia may be present. Another test is pull-out test, that is obstruction to the spontaneous respiration during gradual withdrawal of the endotracheal tube via the fiber optic bronchoscope. Laryngeal USG can be done before extubation, in which we measure the air column width before and after the endotracheal tube deviation, and air column width difference of more than 50% is indicative of tracheomalacia. So what if the tracheomalacia is suspected? And if it is positive, it necessitates reintubation and ventilatory support till the strength of tracheal wall is confirmed, followed by any tracheal support in long term. Pneumothorax, it is very rare, and it may occur during the surgical resection of retrosternal goiter. So the management includes wide bore needle into the second anterior intercostal space, or if tension pneumothorax develops, insertion of chest tube is indicated in these patients. Hypoparathyroidism. It may occur because of ischemic injury or accidental removal of parathyroid glands during thyroidectomy, and acute hypocalcemia may occur 36 to 72 hours post-operatively. The symptoms may be peroral tingling, mental confusion, muscular twitching, tetany may occur. The patient may land up into laryngospasm and dysarrhythmias, and that it is confirmed by eliciting the Chopsticks and Trozius sign. And the treatment includes IV calcium gluconate or calcium chloride 10 ml 10%. And 47% of patients on long-term hypocalcemia may develop hungry bone syndrome because of hypocalcemia. Thyrotoxicosis crisis. The triggers and diagnostic criteria have already mentioned by Dr. Seema, and I will just emphasize the intraoperative and postoperative part of it. So it is an acute life-threatening endocrinal emergency, which is a severe form of thyrotoxicosis, and it exists when the patient's metabolic, thermoregulatory, and cardiovascular compensatory mechanism fails. It is of abrupt onset, and intraoperative thyroid storm may occur during surgery or postoperatively within the first 18 hours after the surgery. The main clinical triad is hyperthermia, tachycardia, hypertension. The patient may have arrhythmias, and intraoperatively the patient has increased bleeding, increased EtCO2. The patient may land up into shock, and we can see that the soda lime exhaustion may occur fast. The most common intraoperative causes of thyroid storm are inadequate depth of anesthesia because of hypoxia, hypovolemia, pulmonary embolism, surgical manipulation of the gland, and uncontrolled hyperthyroidism. Now, the differential diagnosis with these signs, that hyperthermia, tachycardia, and hypertension, includes malignant hyperthermia, neuroleptic malignant syndrome, and pheochromocytoma crisis. So the main known diagnostic laboratory finding confirms the diagnosis of thyroid storm, and whatever the treatment should be symptomatic and as early as possible. So it is said that the heart is convulsing, hot, and hormonal. So the goals of management of thyroid intraoperative and postoperative thyroid storm includes reducing the circulating thyroid hormones, inhibiting the peripheral effect of circulating thyroid hormones, supportive care, and treatment of underlying precipitating cause. General consideration includes inform the surgeon, declare that it is an emergency, call for help, consult endocrinologist immediately. If the patient is intubated intraoperatively, increase the FiO2, optimize ventilation, protect the airway. If the patient is awake postoperatively with oxygen supplementation, establish a second IV line, consider the differential diagnosis, treat the trigger, and according to diagnostic criteria, if the patient is complicated with acute liver failure, plasmapheresis should be done. Supportive measures includes hydration with glucose-containing IV fluids and electrolytes, active mechanical cooling by sponging, cooling blankets, ice packs, and antipyretics in the paracetamol 1 gram can be given IV or per rectally 500 milligram. Maintain the OT temperature, and NSAID should be avoided because it causes a disruption of binding and leading to increased free thyroid hormone levels. Terminate if the patient has a seizures. So terminate the conversion by giving benzodiazepines, lorazepam, diazepam, or midazolam, which is available. Phenytoin can be given, and in refractory, if the seizures continues, then a patient can be induced with 1 to 2 milligram of IV, and mechanical ventilation is done. To reduce the synthesis of new thyroid hormones, thiazide are used. Propylthiouracil, that is loading dose is 500 to 1000 milligram. That is given if the patient intraoperatively by the NG tube or per rectally, and then 200 to 250 milligram 4 hourly, or methimazole and carbimazole could be used. To block the release of preformed thyroid hormone, the Lugol's iodine is indicated, but care should be taken. It is given after the anti-thyroid drugs are given. So after 1 hour after thiazide, you can either give Lugol's iodine, that is 5 to 10 drops. It can be given per orally through nasogastric tube or per rectally, or saturated solution of potassium iodide 5 drops, or hyponoic acid IV can be given. This 1000 milligram 8 hourly for 24 hours, and then 500 milligram 12 hourly. If the patient has arrhythmias in the form of atrial fibrillation, digoxin can be given IV in the divided doses of 8 to 12 max per kg, but it is contraindicated in severe renal dysfunction. Amiodarone can be used in the dose of 150 milligram IV over 10 minutes, and then the maximum dose is 2.4 grams per 24 hours. Start anticoagulation in case the patient is elderly, and if the patient is unstable, synchronized cardioversion can be given to these patients. If the patient has landed up into cardiogenic shock, provide oxygen. Diuretics can be administered, and the vasopressors in the form of IV dovitamin and IV noradrenaline is usually preferred in these hyperthyroid patients. To block the increased adrenergic tone and block the peripheral conversion of T4 to T3, esmolol can be used in the dose of 1 milligram per kg IV over 30 seconds, and then infusion could be started at the rate of 150 max per kg per minute and titrate to the heart rate of less than 130 beats per minute. Or propranolol in the dose of 1 to 2 milligram per minute every 15 minutes up to the maximum dose of 10 milligram can be given. Metoprolol, it is cardioselective, and it can be used if the patient is asthmatic or hyperreactive airway in the dose of 100 milligram per orally or through nasogastric tube every 6 hourly. If the patient has a contraindication to the use of beta blockers, calcium channel blockers can be used, that is diltiazem in the dose of 60 to 90 milligram per orally or NG tube 6 to 8 hourly. Hydrocortisone loading dose is 300 milligram and then 100 mg IV 8 hourly, or dexamethasone 2 milligram every 6 hourly, and total dose of 8 milligram IV per day. So the take-home message is ensure euthyroid status before elective surgery. Choose an appropriate anesthetic drug that avoids sympathetic stimulation. Anticipation and preparation of difficult airway must be done and planned carefully. There should be continuous intraoperative monitoring that is crucial for the condition that require immediate intervention. Post-operative care should be focused on airway patency and managed accordingly. Continue beta blockade to prevent rebound tachycardia. And a well-planned anesthetic approach minimizes the perioperative risks and ensures safe recovery in thyrotoxic patients undergoing thyroid surgery. So thanks from the Gitanjali Medical College and Hospital from the beautiful city of Lakes, Udaipur.
Thank you, Dr. Alka, for giving us an overview of how to manage these patients in the perioperative period. And there were two questions in the mailbox. One was from Dr. Pandit Rao, and he wanted to know what is the emergency intervention in thyroid storm. So though it has been outlined by you, but I think you should give us an overview of it again.
Emergency intervention.
Yeah, like supposing it happens intraoperatively,
So
how would you manage this thyroid storm?
Intraoperatively, if it is you are diagnosed with a thyroid storm, always start the supportive treatment. That is, antipyretics should be given and first protect the airway. The airway should be protected. Hydration should be adequate and start antipyretics. That is, hyperthermia should be reduced. All the measures that are taken for cooling, it should be continued. And most important, start the, if you are not you don't have any availability of thionamides at that moment, at least you start beta blockers, propranolol, atenolol, ismolol infusion, whatever is available that can be used, and infusion should be continued. Along with it, dexamethasone or hydrocortisone. Hydrocortisone is preferred in the dose of 100 milligram, and loading dose of 300 milligram should be given. And if you have availability of thionamides, any form, propylthiouracil, carbimazole, methimazole, whatever is available, it should be started immediately.
What about iodine?
Iodine, ma'am, it is recommended that iodine should not be given directly without starting of thionamides. So first start thionamides, and then after 1 hour, you can start iodine or iodides.
The other question comes, it's more of a statement, I think, from Dr. Lalit. And he says that in large thyroid swellings, you should perform a cuff leak test.
Yeah.
One question for our resident, Dr. Kanupriya. Before doing the thyroid function test, would you like to give some instructions to the patient?
Yes, ma'am. Before we conduct thyroid function test, a brief history about any medications or any supplements that the patient is taking should be taken. Also, especially biotin. Also, if the patient is
Biotin? What is
uh,
biotin?
in biotin is B7, vitamin B7. It is important because many thyroid function tests like TSH, free T3 and T4, they use immunoassays. In those immunoassays, biotin and streptavidin binding, it plays a very important role. So if patient has already is taking biotin, it may hamper the final test results. That is why history, and it is advisable to stop biotin at least 48 hours, 2 days before conducting a thyroid function test. Also, if a patient is
Should they
pregnant,
be fasting? Should the patients be fasting?
um,
Normally, no.
no.
Yeah. So, and,
Also,
anything else?
in pregnant patient, in people who are pregnant, pregnancy is a hypermetabolic state, and because of the hormonal changes, increase in estrogen, it leads to increase in thyroid binding globulin. That will also hamper. That will also bind with thyroid hormones. It will hamper the final test results. Also, in patients who have a history of iodine contrast, that will also hamper the results. So, a brief history before conducting the test should be done.
Thank you, Kanupriya. Over to you, Dr. Meenakshi. I think
I want to say two things about this webinar. One, it was conducted with the military precision because as an organizer, see, many people have covered it within, that is, our idea is to finish before 7:30, but we say 10 minutes, 30, but all the three speakers, 10, 30 is military precision. It is exact timing. I don't know how it was possible. That shows your experience, excellence. 10:30. This is the first time for these 9 episodes I am seeing. And I want to ask all the faculty one question. How many of you are personally seen this thyroid storm?
I have not seen.
Not seen, sir.
Not seen.
See, that is the reason why I want to emphasize we have not seen that. I have also not seen that. But when we are talking about thyroid storm, we say you have to use IV propylthiouracil, IV hydrocortisone, cooling blankets, everything we say. But honestly, we have to think this drugs are not available in the theater. These drugs are not available in the theater. That we have to accept. So that means we are not prepared to face out the eventuality. We presume thyroid storm will not occur. Even though thyroid storm is a short notes for postgraduates in essay, so far we have not seen. The trend continues. But if you are talking about, because questions are also asked, if there is a thyroid storm, what we have to do immediately, definitely we will be caught unawares. That I am sure, because the antithyroid drugs are not available inside the theater. Even IV propranolol, IV metoprolol, I don't know how many people are having it inside the theater. So let us make it as a habit, because safe anesthesia we have to make. So we appeal to all the delegates. Let us make it safe. So at least one IV beta blocker should be available in the theater in emergency tray. Thank you personally, because this is exactly what we wanted to have. So this will be a model for the future people. Now I request Dr. Hema, our treasurer, to propose a vote of thanks.
Hello, good evening, everyone. I thank you all for your participation in today's webinar on thyrotoxicosis in the anesthesiologist perspective. Sincere gratitude to Dr. Elam, sir, our academic chairman, for guiding us through ISA Pudukkottai. Thank you, sir. I thank the Department of Anesthesiology, Geetanjali Medical College and Hospital, Udaipur, Rajasthan, for your commendable presentation today on thyrotoxicosis and the anesthetist perspective. I thank Dr. Kanupriya, postgraduate, Geetanjali Medical College and Hospital. It was a very concise presentation. Thank you, Doctor. Thank you, Kanupriya. I thank Dr.Seema Partani, Professor, Geetanjali Medical College and Hospital, Udaipur, for your presentation on preoperative assessment and optimization in thyrotoxicosis. It was a very commendable presentation. Thank you, ma'am. I thank Dr. Alka, Chhabra, Professor and Head, Geetanjali Medical College and Hospital, Udaipur, on the presentation on anesthetic management on thyrotoxicosis for thyroid surgery. It was a very detailed presentation. Thank you, ma'am. I thank our moderator, Dr. Sunanda Gupta, Professor, Geetanjali Medical College. Thank you, ma'am. I thank ClareNet for your support. I thank all the consultant faculties, postgraduates for continuous support in the ISA Pudukkottai webinar series. Thank you all. Have a good evening. Thank you.
Over to Clarinet for concluding remarks.
Yes, sir. Thank you. Thank you so much, everyone, for giving us the opportunity to host the session. So with this, we can conclude the session over here for today and hope to see you again on our platform very soon. Thank you so much.
Thank you.
Thank you.
Thank you, sir.
Thank you. Thank you.
Thank you, sir. Thank you.
Right.
Thank you.
Thank
sir.
you. Have a nice day to all of you.